Today, I'm going to talk about the part 2 of shortness of breath in adults. In part 1, we talked about how to approach a patient with shortness of breath. So before going into the differential diagnosis, let's recall what we studied in part 1 of this topic. We talked about how a patient would present to you in emergency with shortness of breath. What are the signs and symptoms of impending respiratory failure that you have to identify and you have to treat them before even going to the diagnosis? What does the patient require with shortness of breath? Oxygen, oxygen, and oxygen. We then talked about multiple diseases or different diseases. We'll explain further in this lecture about what might bring the shortness of breath in a patient with in adults. So in this lecture, now we proceed on to differential diagnosis of patients presenting to you in emergency department with shortness of breath. So, airway obstruction. Airway obstruction most commonly is due to the foreign body. How does a patient present to you with foreign body? It's a stridor. Mainly, it's an inspiratory stridor. So patient, when they breathe in, there is an abnormal stridor sound. But what you have to look in those patients, you have to look in this patient if there is any impending respiratory failure or not. You have to protect the patient from going into respiratory failure. So, airway obstruction, foreign body, mass, tumor, or malignancy, nasopharyngeal mass, oropharyngeal tumor, they can present with tracheal tumor, can present with airway obstruction. Angioedema. Angioedema is likely due to the cause of any anaphylactic reaction or drug-induced. Especially the ACE inhibitors can cause angioedema. The patient would present with swelling of the lips, generalized swelling of the face, and inability to speak or cannot speak. But at times the patient is stable, but you have to observe the patient for a couple more hours so the patient is not does not develop angioedema or might need a protective airway. And patients and those patients with angioedema, they need a mechanical intubation to protect the airway. Any infections, upper respiratory tract infections, or tracheal infections can present with airway obstruction. Tracheomalacia or tracheal stenosis can present with airway obstruction. Tracheomalacia is most commonly in childhood. The patient might present with signs and symptoms of airway obstruction. Lungs, pulmonary and parenchymal diseases. So before going further, let's recall what are the signs of impending respiratory failure. Increased respiratory rate of more than 35, use of accessory muscles, hypotension, altered mental status, coma, decreased GCS, accessory muscles, use of sternocleidomastoid muscles, which is commonly in patients with airway obstruction in foreign body. This with intercostal retractions, one can identify this patient is in severe air hunger or severe dyspnea, or this patient is in impending respiratory failure and needs an adequate and advanced oxygen therapy. So moving on to some differential diagnoses related to lungs and parenchyma. For example, asthma, chronic obstructive pulmonary diseases. Asthma is most commonly in patients and in seasonal. There are seasonal patients who get exacerbation in winters, and especially features of following a lower respiratory tract infection or an upper respiratory tract infection or flu-like symptoms. So patients with a history or an exacerbating factor can present with acute exacerbation of asthma. The patient, how would they present? They present with wheeze, the hyperrespiratory rate, and cough might be the presenting symptom. But again, you have to see that you have to rule out the impending respiratory failure. Then you should go on for history and examination. Likewise, in chronic obstructive pulmonary diseases, patients with history of smoking or patients of COPD, history of COPD can present, especially in winters, or post-infectious status can present with shortness of breath and symptoms of acute exacerbation. Usually, patients with asthma and COPD have a long-standing history or have a previous history of similar attacks, especially in winters or following an upper respiratory tract or lower respiratory tract infections. So moving on to infection and trauma. Infections include pneumonia is the most common cause. That might be two: hospital-acquired pneumonia, the patients with long-standing admission in hospitals, or patients with a community-acquired pneumonia. Elderly, more aged, advanced age, diabetic, hypertensive, immunocompromised have a history and are highly susceptible to get the pneumonia or infections from within the lung parenchyma. Other than infections, trauma, especially pneumothorax, tension pneumothorax, or spontaneous pneumothorax can cause a lung parenchymal disease. So how to differentiate patients in tension pneumothorax? Tension pneumothorax is unique with a tracheal deviation to contralateral side, distal and jugular venous veins, and hypotension. Patient might be hyperresonant on the affected side, but the tracheal deviation to the opposite side. We'll talk about in detail in the next section how to treat these traumatic patients and how to treat this pneumonia and other symptoms leading to lung parenchymal diseases. Pulmonary edema, again, sign and symptom of many diseases. For example, acute myocardial infarction, especially anterior wall MI, with low ejection fraction. Patients with mitral valve regurgitation, for example, mitral stenosis, can present with signs of pleural effusion. Patients with acute and chronic kidney diseases can present with pulmonary edema and pleural effusion. Patients with long-standing recurrent and lower respiratory tract infections can present with pulmonary edema. What are the differentiating points in patients with pulmonary edema due to acute myocardial infarction or long-standing congestive heart failure? They might be having a S3 gallop rhythm, distended neck veins, peripheral edema, shortness of breath, and orthopnea. Orthopnea is, again, shortness of breath on lying down. Moving on to atelectasis and bronchiectasis. Bronchiectasis is also a commonly caused symptom which leads to the disease of lung parenchyma. Atelectasis is collapse of the alveoli, which leads to shortness of breath and lung parenchymal diseases. Pulmonary fibrosis. Patients with interstitial lung diseases can progress to pulmonary fibrosis. Patients with recurrent infections can present with pulmonary fibrosis. Patients with environmental lung diseases, for example, patients who are coal miners, patients who work in factories that manufacture ship or marbles or stones, can with long-standing history can present with environmental diseases affecting the lung parenchyma. For example, coal worker pneumoconiosis, asbestosis, silicosis. These can present with signs and symptoms of shortness of breath and lung parenchymal diseases. Adult respiratory distress syndrome, ARDS, is most common in patients with hospitalization. There is chest X-ray typically shows the lung white out. There is decreased FiO2 values. So these patients could present with lung parenchymal diseases. Rheumatological and autoimmunological diseases, especially patients with systemic lupus erythematosus. Patients with lung cancer can present with shortness of breath or mass in lung parenchyma could present with shortness of breath. Moving on to pleura. Pleura includes trauma, again, tension pneumothorax, spontaneous pneumothorax, flail chest. These can produce diseases of the pleural cavity. Atraumatic, which includes tumor of the pleural space, which includes mesothelioma, most commonly with asbestosis poisoning, can present with shortness of breath and worsening symptoms of shortness of breath. Pleurisy includes pleuritis, while pleuritic chest pain or fever can present with signs and symptoms of shortness of breath and parenchymal and pleural diseases. Chylothorax and pleural effusion can also present with shortness of breath and signs and symptoms of respiratory compromise. Pleural adhesions are also the cause of signs and symptoms of respiratory tract infections. Long-standing pleuritis can present with pleuritic adhesions. Mass, again, as I said, mesothelioma, most common tumor of pleural cavity is mesothelioma, highly associated with asbestos poisoning, can present with shortness of breath and signs and symptoms of respiratory compromise. Chest wall abnormalities, trauma, again, Then there would be patients with long-standing COPD. They can have a barrel chest. Patients with kyphosis can present with chest wall abnormalities and increase in respiratory tract symptoms. Decreased lung volume due to interference with chest expansion, which mainly is suffered due to the abdominal distension, especially in ascites. Abdominal distension, patient with gross ascites, HEPS-related decompensated liver diseases, portal hypertension. Also, is in patients with, who are pregnant, especially in gestational ages of 30 weeks. They present with more abdominal distension and shortness of breath. Abdominal mass, lungs or big mass, which encompass most of the abdomen, for example, gastric tumor, liver tumors, or any tumor which causes increased mass of pressure on the lungs, can cause shortness of breath and symptoms of respiratory tract compromise. Diaphragmatic injury, patients with cervical collapse, patients with long-standing cervical injury, neuromuscular dysfunction can present with diaphragmatic injury. Ruptured diaphragm, patients with traumatic injury can present with ruptured diaphragm and eventually leads to unilateral diaphragmatic paralysis and hence a shortness of breath and signs and symptoms of respiratory tract compromise. Paralysis of diaphragm in multiple diseases, for example, myasthenia gravis. For example, patient autoimmune diseases, periodic paralysis can present with diaphragmatic paralysis. Duchenne muscular dystrophy can present with paralysis of diaphragm. So moving on to differential diagnosis, which present with shortness of breath, with cardiac abnormalities that present with shortness of breath. What might be the cause of cardiac causes of shortness of breath? First, we'll move myocardium. What happens is there is with acute ischemic insult, there is decreased wall motion abnormalities. With increased wall motion abnormalities, there is decreased range of wall motion of the heart chambers. What happens then is there is decreased cardiac output. There's back pulling into the pulmonary vessels and eventually leads into pleural effusion and pulmonary edema. So these patients present with acute signs of congestive heart failure. There are two types of myocardium of congestive heart failure: right-sided and left-sided. With left-sided heart failure, there are signs and symptoms of pleural effusion, pulmonary edema. While with right heart, there is distended neck veins, peripheral edema, or distended or hepatomegaly or condition of liver functions. So moving on to pericardium, with pericarditis or involvement of pericardium, there is decreased diastolic phase of cardiac chambers, which leads to back pulling of the blood again and again. The heart on auscultation would show muffled heart sounds. This might present with signs and symptoms of pleural effusion and distended neck veins as well. So this is typically of pericarditis, a back triad. That's hypotension, distended neck veins, and muffled heart sounds. So this back triad, eventually the mechanism, pathophysiology remains the same. There is decrease in diastolic time, eventually leading into back pulling of the blood into the lung parenchyma and eventually to pleural effusion, pulmonary effusion, and hence shortness of breath. Moving on to valvular, mitral valvular abnormalities could lead to pleural effusion and signs and symptoms of respiratory compromise because of pleural effusion especially due to mitral valve, leading to shortness of breath. Moving on to cardiac, which includes, as I mentioned, acute myocardial infarctions, ischemic heart diseases, valvular abnormalities. They could exacerbate the pleural effusion and respiratory compromise. Outflow tract obstruction because of aortic stenosis. Aortic stenosis, there is increased chances of increased heart sounds because the heart has to move against the stiff aortic valves, and which leads to back pulling and again pleural effusion and respiratory compromise. Congenital heart diseases, especially tautology of Fallot, patients with cyanotic heart diseases and patients with acyanotic heart diseases can present with pulmonary symptoms, especially as in Menger syndrome can present with right heart failure. It eventually leads into congestive heart failure. Dysarrhythmias, atrial fibrillation can present with acute onset of acute cardiac failure, leading into pleural effusion, and hence leading into respiratory compromise and respiratory tract symptoms. And again, this can present with shortness of breath, and when you check on the EKG, you find atrial fibrillation. Remember, in part 1, we talked about the chest pain. Chest pain is very, very important in knowing if the cause of shortness of breath is due to cardiac in origin. Because if a patient is complaining of chest pain, a simple EKG would give you a lot of information. Dysarrhythmias, which includes atrial fibrillation with fast ventricular rate, could be a cause of acute cardiac failure, and acute cardiac failure leading into pulmonary compromise. Decreased cardiac output, again, wall motion abnormalities, leading to decreased ejection fraction and a decreased output of the cardiac from the cardiac chambers, leading to back pooling and increased accumulation into the pulmonary vasculature, leading into pulmonary edema and pulmonary fluid overload. Heart failure, as I mentioned before, there are two types: congestive heart failure, which includes right-sided and a left-sided heart failure. So most important cause is myocardial ischemia. Again, dysarrhythmias, valvular heart diseases, pericarditis. These can all cardiac tamponade. These can all help exacerbate this pulmonary signs and symptoms of shortness of breath. Moving on to vascular emboli, for example, a patient with a long-standing history of deep venous thrombosis. Let's take an example. You receive a patient in ED, and you are asked to evaluate the patient who presents to you with sudden shortness of breath. There are no signs, any physical or no findings on chest examination. You find the chest is clear, heart rate is 130. When you examine the patient, you see there is a unilateral leg swelling. You ask the patient, is for how long, if it's tender or not. If you see all of these symptoms, think of an emboli. Think of an emboli which has transmitted from the deep veins to the pulmonary vasculature. Otherwise, the other source of emboli could be a cardiac. For example, patients with long-standing atrial fibrillation, there is increased chances of cardiac emboli, which can be transmitted to pulmonary vasculature, and hence pulmonary embolism could be there. And this is the reason why these patients are put on anticoagulant for much of the time, just so that the emboli could not propagate into the pulmonary vasculature or to the brainstem, which leads to cerebrovascular accidents or pulmonary embolism, respectively. So pulmonary hypertension, again, pulmonary hypertension can be due to right heart strain, or patients with pulmonary embolus can present with pulmonary hypertension. Veno-occlusive diseases, sickle cell diseases. Sickle cell diseases also has a variety of phases. For example, bone marrow crisis. They can also present with muscular abnormalities that can present with shortness of breath and signs and symptoms of respiratory distress syndrome. Vasculitis, autoimmune etiology could be also the cause of shortness of breath in patients with autoimmune diseases. AV fistula can also present with shortness of breath due to changes in intrathoracic pressure and other things that are associated with shortness of breath and respiratory compromise. So, moving on to differential diagnosis of respiratory tract symptoms that are due to neurological or muscular disorders. As I mentioned in the beginning of this lecture, there are multiple injuries that can lead to a respiratory compromise. So neurological and muscular is one of them. Moving on to neurological, if the patient is had an central or central nervous system accident, for example, cerebrovascular injuries, patients with basal ganglia infarct or infarct in pons can lead to respiratory compromise because of suppression of respiratory centers. Traumatic injuries and infections in cerebrovascular accidents, for example, meningitis, meningoencephalitis, subdural or subarachnoid hemorrhage post-traumatic can lead to sudden suppression of the respiratory system. Botulism and organophosphate poisoning, toxins and opioids can always depress the respiratory system and decrease the respiratory effort, and that is why the patients with acute exacerbation of asthma or COPD or acute exacerbation of respiratory symptoms, it is contraindicated to use an opiate or any sedatives, because that cause central nervous depression, and which leads to decreased output from the respiratory centers. Moving on to spinal cord, traumatic spinal cord injuries. Spinal cord diseases can lead to respiratory tract symptoms. Peripheral nerves, peripheral neuropathies, Guillain-Barré syndrome can lead to respiratory symptoms. Tetanus, it is a disease, especially patients with post-traumatic and who are not been immunized with antitoxins, can lead to paralysis of the respiratory muscles and systems. Take paralysis can lead to neurological disorders supplying the respiratory system, and hence leading to respiratory compromise. Muscular dystrophies, muscular causes of shortness of breath includes myopathies, myasthenia gravis, poliomyositis. Muscular dystrophy, Duchenne muscular dystrophy, most common in young children, males with advancing age. It's not present in the childhood, with the advancing age apparently from 8 to be precise. They present with a sudden paralysis of the muscles involved, and eventually leading into a respiratory system and a respiratory compromise. Glycogen storage diseases, again, a congenital diseases, biochemical diseases, which leads to a decrease to respiratory compromise. Periodic paralysis, again, with multiple diseases which involve neurons, ascending and descending neurons, which are affected in those diseases, can present with respiratory compromise. So, other causes of respiratory compromise. Anemia, because of decreased anemia, there is decreased oxygenation to the pulmonary vasculature, and eventually leading to pulmonary compromise. What happens in anemia? The patient would complain, have a similar, and occasionally, most of the time, the complaint would be if they walk for some time, patients who are anemic, if they do any exertion or they walk for some time, they feel dyspneic and they feel dizziness. And the patients with long-standing chronic anemia or anemia due to chronic diseases could present with respiratory compromise and some signs and symptoms of respiratory compromise. Methemoglobinemia, also a poisoning, also present with carbon monoxide poisoning. Patient present with increased dizziness, increased incidence of vomiting, especially in winters in developing countries where coal and woods are used most of the time, and unburned coal or oxygen give you carbon monoxide, and this carbon monoxide poisoning, excessive carbon monoxide poisoning, helps dissociate the oxygen from the hemoglobin, and eventually leading into the carbon monoxide poisoning. As it was studied in physiology, carbon monoxide has high potency or high binding capacity with hemoglobin as compared to oxygen. So simple ABGs and levels of carbon monoxide, carboxyhemoglobin could help you identify, and the treatment would be high flow oxygen. So the gastrointestinal causes, which includes gastrointestinal reflux diseases, can present with signs and symptoms of shortness of breath. It is rarely, but at times, can present with signs and symptoms of respiratory irritability. Abdominal loading, as I mentioned in the previous slides, patient with gross abdominal distension, for example, patients with SITs due to decompensated liver diseases, portal hypertension, liver cirrhosis, mainly in patients with hepatitis C, which are progressive to decompensated liver diseases, can present with ascites and abdominal distension. So these patients present with signs and symptoms of respiratory compromise as well. So the cause is the abdominal swelling. So what we do, and as an emergency to relieve the signs and symptoms of respiratory compromise, we drain out the ascitic fluid, and this helps relieve the patients from the symptoms. Other thing is the pregnancy, which leads to respiratory compromise because of the abdominal loading. Moving on to some toxins and the poisons, which includes carbon monoxide poisoning. As I mentioned before, carbon monoxide poisoning is lethal if taken in much higher quantity, or long-standing exposure to the carbon monoxide could help you, could cause a serious disastrous effect. Because carbon monoxide is the highest binding potency with the hemoglobin as compared to the oxygen. So dissociation with the from the hemoglobin is very, very difficult. So we have to give this patient a high flow oxygen. Drugs, which includes organophosphate poisoning, sedatives, which can cause respiratory compromise, and respiratory arrest as well in patients who are taking high dose of opiates and who are taking drugs. Psychological hyperventilation syndrome, it's more commonly in females who are prone to panic attack or anxiety. They have a psychological issues which help them to hyperventilate because of anxiety and apprehension, which leads to respiratory compromise as well. Anxiety again and panic disorder, acute panic attack could at times present with hyperventilation syndrome. So what we do we give a back mask and ask them to breathe inside. So this can help to relax and calm down the signs and symptoms of panic disorder. Deconditioning can cause acute symptoms of respiratory compromise. So, differential diagnosis, let's summarize: cardiac output, decreased cardiac output, cardiogenic shock, low cardiac output, again, pleural effusion, pulmonary edema leading to respiratory compromise. Metabolic renal, which includes diabetic ketoacidosis. Patients with type 1 diabetes especially can present with increased rate of respiration because of anxiety and because of the signs and symptoms of dehydration as well. So these patients have a typical acidotic breath, fruity smell breath. You can see the lectures of diabetic emergencies to read about diabetic ketoacidosis. Metabolic acidosis, especially patients with chronic kidney diseases, could present with metabolic acidosis, that is pH of less than 3.5, 7.35, and bicarb is less than 12 in these patients. So these present with fluid signs and symptoms of fluid overload, and these patients might need urgent dialysis. As I mentioned before, renal diseases, chronic kidney disease or AKI on chronic kidney disease could cause acute respiratory symptoms with fluid overload. Endocrine, thyroid diseases, and Cushing disease, thyroid storm, the emergency condition of thyroid disease can present with signs and symptoms of respiratory compromise. So moving on to general life treatment principles. Before going further, let's recall what we talked about in lecture 1, part 1 of this section. When you receive a patient with shortness of breath, first and the foremost thing you do is supply oxygen. So what are the immediate life-saving maneuvers to be done? Maintain the airway. How to assess the patient's airway? If the patient is talking, if the patient can tell you his or her name, that's a sign of airway, patent airway. But the patient is of altered sensorium, or patient with altered mental status, you have to protect the airway first. Either you have to put oropharyngeal airway, or this patient might need an endotracheal tube intubation. Give oxygen supply. Why is oxygen so much important? When you receive a patient with decreased pulse oximetry saturation, give this patient an oxygen. Patient needs oxygen and oxygen. What are the modes of oxygen that could be given? That's another thing to be talked about. But for now, the immediate and general treatment principle, the airway should be maintained. Next, give this patient an oxygen. Continuous monitoring of pulse oximetry, heart rate, blood pressure, and EKG. It is important to measure the patient's pulse oximetry because it gives you a sudden reading and appropriate. At times, it's not specific. For example, a patient with methylglobinaemia can present with 100% saturation. So, pulse oximetry, heart rate, vitals are very, very important in patients assessing with shortness of breath. Increase in heart rate is a compensatory mechanism, can help you identify this patient is in compromise. What other features are inclusive of patients with impending respiratory compromise? Respiratory failure, again, I repeat again because it is very, very important. Use of accessory muscles, patient cannot complete the sentence, air hunger, altered mental status, irritability, decreased GCS. These are the signs of impending respiratory failure, and you need to address them first before even going into the diagnosis. So first you did was maintain the airway. Even if you have to tube the patient, you tube the patient, because maintenance of airway is very, very important in almost all of the diseases that you encounter in emergency department. This patient needs oxygen. This patient should be monitored with pulse oximetry, heart rate, and blood pressure. Continuous monitoring is required. Set the patient upright. What happens is when you ask the patient to sit up, there is decreased pressure on the chest cavity from the abdominal content, help relieve the pressure, and the patient gets symptomatic relief with the proper position. So it is recommended if the patient, especially in patients with acute cardiac failure or congestive heart failure, this patient should be given an in upright position, so that the abdominal contents are lower down and releasing the pressure on the chest cavity. If possible, airway obstruction, do not lie the patient flat, lean, or backward, or use the tongue blade or in the mouth. In the patient, if there is foreign body obstruction, examine the oral cavity the way you how much you can, and if you find any foreign body, you can manually evacuate. Otherwise, Heimlich maneuver could be used in patients, especially in children who are more prone to ingest a foreign body, especially beans, coins, etc. Heimlich maneuver at times is very, very beneficial, help relieve the foreign body. May try non-invasive ventilation. Non-invasive ventilation comprises of two things: continuous positive airway pressure, that is CPAP, and the next is BiPAP, that is bi-level positive airway pressure. CPAP is most commonly used in patients with acute pulmonary edema, while BiPAP is widely used in much of the cases. BiPAP, why it's called BiPAP? Because it has a fixed ratio, which can be fixed by the requirements of the doctor or the physician. It gives you a positive pressure with ventilatory support, while CPAP give only the ventilatory support. In BiPAP, there is inspiratory positive airway pressure and expiratory positive airway pressure. Inspiratory is kept at the higher side, and expiratory is kept at the lower side. So IE ratio is recommended, that is 1:2 and 1:3. Multiple diseases can be treated with NIV, for example, acute pulmonary edema, patients with acute exacerbation of COPD, patients with retaining carbon dioxide, that is hypercarbia or carbon dioxide narcosis, which are affecting the brain stem or brain or altered mental status, could easily excrete, give more time to excrete the carbon dioxide which is retained inside. This NIV BiPAP is very, very useful and help to prevent the patient from going into ventilatory support. Emergency airway management. If patient is not tolerating airway with the NIV or is not getting better with NIV, go for mechanical intubation. And if you suspect a foreign body, you can go for urgent tracheostomy or cricothyroidectomy. So, acute exacerbation of COPD. So, let's talk about some of the common diseases, especially in winters, or a patient with exacerbating factor that you might encounter or come across in patients in emergency department. In winters, patients with asthma or COPD with a history or flu-like symptoms or upper respiratory tract infection or lower respiratory tract infection can present with sudden onset of shortness of breath. When on auscultation you find a wheeze. With COPD, you can find a central or peripheral of the cyanosis, digital clubbing, pursed lips, and increased expiratory phase. So these are the signs and symptoms you come across in the patients with acute exacerbation of COPD and asthma. Usually, these patients have a history of similar episodes in the past, related to flu-like symptoms, or especially in winters or seasonal allergies, which exacerbate these symptoms. How do you treat these patients? First, if you find a wheeze, you have to nebulize these patients with short-acting beta agonist, that is salbutamol. Next, you can give long-acting with ipratropium bromide that is beneficial in asthma and COPD as well. Giving IV steroids is very, very beneficial in patients with acute exacerbation of asthma and COPD. 100 milligram of hydrocortisone IV or oral methylprednisolone 40 to 50 milligram orally could be given in patients with acute exacerbation of asthma and COPD. So, anticholinergic bronchodilators, ipratropium bromide, corticosteroids, 100 milligram of hydrocortisone could be given in symptoms of acute exacerbation of COPD and asthma. Also, while working in emergency department, especially in patients with acute exacerbation of asthma, magnesium sulfate is highly recommended as well, because these are bronchodilators. Bronchodilators are widely used, but you have to keep in mind the magnesium sulfate could cause a serious arrhythmias and cardiac electrical abnormalities as well. But with life-threatening asthma, you have to give magnesium sulfate, that is 1.2 to 2 gram over 20 minutes. We'll talk about in detail about these diseases specifically in the next lecture, which involves the most detail about the pathophysiology and the treatment in emergency department. So we are just going through a general treatment principles. Antibiotics, if there is a bacterial cause that has exacerbated chronic obstructive pulmonary disease or asthma. And pneumonia, again, maintain the airway, give this patient oxygen, obtain blood samples, cultures. If there is sputum production, go for a sputum culture, gram staining. This patient needs antibiotics. Pneumonia could be classified in 2 types: community-acquired pneumonia and hospital-acquired pneumonia. And the treatment remedy remains the same: antibiotics and antibiotics. You have to make sure there are certain guidelines to follow while patient with pneumonia. You have to stratify the risk in patients with pneumonia. For example, you might be having an idea of curve 65, that is confusion, uremia, increased respiratory rate at advancing age could be due to that could cause increase in curve 65 score is an indication for intensive care unit admission and aggressive treatment for pneumonia. Congestive heart failure. These are several mnemonics we'll go through one by one. So that is unload me first. That is upright position. Then you can give nitrates and nitroprusside. Why nitrates are important? Because it decreases the preload and afterload. So it decreases the cardiac workload and decreases the cardiac pressure. So eventually the patient gets symptomatically better. Lasix, that is diuretics. In patients with congestive heart failure, the treatment remedy is diuretics and diuretics. You put on the Foley's catheter, you pass the Foley's catheter, and you give the patient, you start off with diuretic, that is furosemide loop diuretics, 80 milligram initially, and you can go up to 200 milligram of IV furosemide. Oxygen, again, first, because of this mnemonic, it's easy for you to understand and to remember what should be given, but oxygen is the first priority. Give this patient oxygen and oxygen and oxygen. Then ACE inhibitors and aspirin. ACE inhibitors are widely used in patients with congestive cardiac failure, and patients with acute myocardial infarction, they should be put on an ACE inhibitors and aspirin. They should be put on ACE inhibitors after 24 hours because they decrease the cardiac mortality and morbidity. While an aspirin is the worldwide use, and it's recommended within a few minutes if you're suspecting acute coronary syndrome. It decreases the mortality of patients with acute coronary syndrome. Dopamine and dobutamine. These are inotropic agents, especially patients with congestive heart failure have a baseline of lower blood pressure. But when you give the diuretics, there is increased chances of further decreases in the blood pressure and leading to hypertension. So these patients might need dopamine and dobutamine, that inotropic supports, to build up the pressure that is required for adequate organ perfusion. Also, this can increase the renal supply, blood supply, and hence increase the glomerular filtration rate and increase diuresis of the patients who are on inotropic support. Morphine sulfate in patients with chest pain, nuanced chest pain. First, because chest pain is a stress factor that exacerbate the chest pain and signs and symptoms of acute coronary syndrome. So morphine sulfate give the patient a pain relief and help to withdraw the stress factor that's on coronary arteries. Then endotracheal tube intubation if required. Again, this is a mnemonic just for you to remember, or easy to remember what to do in patients with congestive heart failure. But again, the order should be the other way around. Maintain the airway, might need endotracheal tube intubation, oxygen supply, and then further treatment. Again, this is another mnemonic that is moist and damp, morphine sulfate, oxygen, inotropic support, sitting upright and salt restriction, tonicates, aspirin, nitrates and nitroprusside, diuretics and dialysis in patients if required, digoxin for controlling atrial fibrillation, ACE inhibitors, cardiac and pulse oximetry, blood pressure monitoring, posterior pressure ventilation or phlebotomy if required. Again, this is another mnemonic, LMNOP, that is Lasix, morphine sulfate, nitrates, nitroprusside, oxygen, and upright position. So pulmonary embolism. What are the risk factors for pulmonary embolism? You receive a patient who is bedbound or the patient's what might be the risk factors in patients when you can suspect a pulmonary embolism? A patient with sudden onset of shortness of breath. You receive tachypnea, is their heart rate is more than 120. There is ongoing chest pain, blood pressure is slowing down. What to expect in this patient? On chest examination, you find nothing. You find a chest bilateral clear and equal air entry. What to expect in this patient? Pulmonary embolism first. What are the risk factors for pulmonary embolism? OCPs, oral contraceptive pills, bed-bound, recent surgeries, deep vein thrombosis, antiphospholipid diseases, sickle cell diseases, systemic lupus erythematosus. These can present with pulmonary embolism. Coagulation disorders can present with pulmonary embolism. So what to do in this patient? First, airway, maintain the airway, oxygen supply, morphine sulfate, and then give heparin. Heparin is advisable 80 units per kg start dose, and you can start off with infusion if required. Warfarin for long-term therapy in patients with a pulmonary embolism and massive pulmonary embolism. Again, this topic will be talked in detail, specifically and separately, and when we talk about the diseases that are commonly encountered in emergency, that the main symptom is shortness of breath. So central airway obstruction. Treatment depends on the oxygen and ventilation, followed by treatment depends on etiology, allergic and anaphylactic reactions. Epinephrine is the drug of choice in patients with anaphylactic reactions because vasoconstrictions. Also, you can give diaphragm, hydramine, and corticosteroids. This help to decrease the histamine release and help to relieve the symptoms. Bacterial infections, IV antibiotics, foreign body, laryngoscopy if required, bronchoscopy if required, and radiation therapy or chemotherapy if required due to a tumor or a mass in the airway, in the central airway. So moving on to some special patients, especially elderly. In elderly, there is increased chances of respiratory and cardiac compromise because of advancing age. patients who have multiple comorbidities, for example, asthmatics, patients who are elderly who are asthmatics, or chronic obstructive pulmonary diseases, or patients who are diabetic, hypertensive, or patients with congestive heart failure could present with sudden shortness of breath and respiratory compromise. So these patients are at times hard to treat, but again, the remedy remains the same: oxygen, maintain the airway, and treat the cause. So elderly patients are more susceptible to be visited in ER with shortness of breath because of the cardiac dysfunctions that are due to age, or senile dystrophies that is due to age. The patients with neuromuscular problems or neuromuscular dysfunctions could present are more in elderly males and females, so they can present with shortness of breath. They have most of the patients are bedbound. They have a history of ischemic stroke. They are bedbound. They are not mobile. They can present with signs and symptoms of pulmonary embolism. So elderly patients are more prone to get a shortness of breath if they have a previous comorbidities. Moving on to pregnancy, as we mentioned before, in pregnancy, there is increased chance of shortness of breath because of the abdominal loading that is more in gestational age of 30 weeks. So these females could more prone to get shortness of breath. So it's recommended that these patients should be in a left lateral position so that the inferior vena cava is not compromised and there is decreased pressure on the chest respiratory system, and eventually leading into low signs and symptoms of respiratory compromise. So disposition of these patients. Disposition is very important to know while working in emergency department. You must know where this patient is going. For example, if the patient is with severe episode of asthma or life-threatening asthma, this patient is a candidate for hospitalization. If the patient is with moderate asthma and the symptoms have relieved, this patient can go home easily. Also, similarly, it happens in chronic obstructive pulmonary diseases. Patients who gets relief with the treatment in emergency could be sent home with close follow-up to pulmonologist and a general physician for monitoring. Patients with pulmonary embolism, most of them require a hospitalization. Patients who are elderly and prone to get acute respiratory syndromes, or patients with adult respiratory syndromes require a medical hospitalization and ICU care. Patients with pneumonia and increased risk of complications should be admitted and should be treated and should be given IV antibiotics. So in this lecture, in this part 2 of this lecture, we talked about much of the diseases, much of the causes that can present with shortness of breath, which involve the cardiac causes, the respiratory causes, and the neurological causes. We then talked about the general treatment principle that is to be done in all the patients with respiratory compromise. For example, maintaining the airway, oxygen supply. Then we talked about a few of the treatment remedies in patients with asthma and acute exacerbation of COPD. We did talk about some of the treatment plans in congestive heart failure. We talked about some of the mnemonics that can be helpful for you to remember in patients with congestive heart failure, the treatment of congestive heart failure. We then talked about the pulmonary embolism. We then talked about the special patients, which includes elderly and pregnant females. What should be the disposition of the patient? That we'll discuss at the end of this lecture. That's all for now. Thank you for watching sqadia.com.